I thank you all for giving me this opportunity, especially Dr. Professor Rohit Shetty, because he's recognized this 15 years back at AIOS when we spoke about this. Where do we go next? So I'm going to go at max 7 because it's late in the evening, and if I whiz by, then probably I'll wake you up. So this is what it is. So this is a neuropathic ulcer, and on the right side you can see the ulcer, and on the other side you can see the ulcer healed and the corneal opacity regressing, and this is after putting the sural nerve and replacing the nerves back in the cornea. So this is the kind of thing you get, and you may sometimes not need a corneal transplant at all when you do a sural nerve transplant or a direct neurotization back into the eye. This is one of the earliest things that Rohit and me had talked about. I am basically also an oculoplastic surgeon who does a lot of cornea-saving eviscerations. So I had done cornea-saving eviscerations where I used to go halfway, go along, save the long ciliary nerves, and do not damage the nerves at all. Keep the nerves even if you have just the shell. And these are cases which we have, which over 14 years, 15 years, the cornea is still transplant without any aqueous inside, with a hydroxyapatite implant, which you can see there. There's only one area where the vessel is seen, and that's the area where I inadvertently cut the nerve. Because when we went into video audits, we saw that is where we cut the nerve. So innervation is something which is most important for corneal transparency. So this is the monkey chaos that I was talking about with Dr. Rohit. I mean, this is one of the best heutagoggies and academic goggies. I'm throwing a question, what are the factors necessary for corneal transparency? And innervation is one of the most important factors. We know all the anatomy, so I'm going to run through the other things. The nerve distribution, we know that there are different kinds of nerves, but what we do have is a nerve plexus. So if you have a foreign body and somebody tells you, I cannot tell you where the foreign body is, then it's on the cornea. But if you see a foreign body and he tells you, yeah, I think it's on the upper eyelid on the other side, then it's a subpalpable conjunctival foreign body. So the plexus is what is important, and you have multiple nerve fibers. You also have autonomic nerve fibers in the cornea, which most of us do not talk about. And if the autonomic nerve fibers have been disrupted, no matter what you do, you take sural nerve, you take anything, that patient is not going to improve. That is a whorl-like sensory pattern when the subbasal plexus comes subepithelial and makes this whorl. And I put this slide here because it is important to see this after your cataract surgeries, even after cataract surgeries. Each nerve has a covering, so it's a coat, and the stem cells are within the coat. So the stem cells for this is within the coat, stem cell for this is within the coat, the stem cell for each nerve fiber is within that small coat. And if I disrupt that stem cell, the nerves are not going to grow. The reasons for neurotrophic ulcers can be anything right from the origin to there, and you can also have it even in keratoconus. So you have this increased tortuosity, and patients like this coming in keratoconus as well. So there is a neurotrophic disease pattern even in keratoconus. Now what happens is, like, I have my lip peeling, and the nerves tell me that it's dry and it's peeling and my lip keeps forming. But if it keeps on peeling, it becomes thin. If I rub my lip, it becomes thin. So the stem cells will not produce. The stemness of the stem cell depends on the nerves. So the innervation tells you, come on, there is a gap there, go fill that gap. So the central innervation has to be told to the brain to send in factors there. Now, many of us think that, no, this is only for the dry eye guys or only for the corneal surgeons or oculoplastics. But after cataract surgery, what is the importance of corneal nerves after cataract surgery? So it has been proven now that after cataract surgery, even after a routine uneventful phacoemulsification, your subbasal nerves plexus is depleted. So I have in my city in Bombay a lot of actors who come in, deliberately go bald and for a show or for a movie, and then they grow their hair back. To those, I need not give them an oil to make them hair come back. The hair is going to come back again. So I will give treatment and the hair comes back again. I will claim credit for that. So there has to be a little time given for that. So if you see this, most of them return back to normal. The more interesting thing is, you do a phaco on this side. The subbasal plexus on this side reduces, but the subbasal plexus on the other side also reduces. So there is something called a sympathizing. So if you do a cataract surgery and you do a sequential cataract surgery, when you're doing the cataract surgery of the other eye, you tap the aqueous and send it for inflammatory markers. If this eye has been operated, the other eye also has increased inflammatory markers. So there is a little bit of sympathizing which occurs even after cataract surgery. It goes to the level of the subbasal level also. Now, they have, sorry. So, these are images of a patient which have been taken before surgery, before cataract surgery, and at 1 month. And you see there is confocal evidence that this actually happens, and this has been presented in RO as early as 2020. Now you talk about cataract surgery in diabetics more often. India is now the diabetic center of the world. So you see more and more diabetics. So when you see these patients, so most of these patients are some of these patients which may have a neuropathic, neurotrophic subbasal loss. So I'm sitting on my leg has become numb. When I get up and I start walking, I get tingling and I get hypersensitivity and I get this neuropathic pain. So these are the guys who are recovering, they recover on their own, and that's the time when they're getting that pain, and then that pain goes away. So these are the guys who are going to eat your head after a cataract surgery, even after 2 to 3 months. And in diabetics, you know that these confocal microscopy shows changes even in diabetic keratoneuropathy, which has got nothing to do with cataract surgery. Your diabetic keratoneuropathy is a harbinger of diabetic foot. So if you have diabetic keratopathy, in All India Institute of Diabetic Association in Mumbai, I have been seeing, and in 2014 I have said that this patient is going to get a diabetic foot amputation because his corneal nerves are gone, and those patients have in 2024 come with an amputation. So this is a harbinger of diabetic foot. Oh, I'm already done. So regeneration follows degeneration, and those are the different levels of degeneration. When this break happens, there is something called as Valerian degeneration, which goes all the way up. If that is damaged, it's not going to improve. So there are various channels which are there, and then we know that the PNS, the peripheral nervous system, is better. So my original concept was to take the, instead of taking the sural nerve, take the supraorbital, supratrochlear nerve, turn them around and put it into the cornea. And I thought this would work, and this is what something I called as my technique. But then I realized that the PNS works better because the Bugner's bands happen better in the PNS. Then we started doing the sural nerve, and in the sural nerve, we started looking at intelligence, artificial intelligence, looking at the sural nerve, artificial intelligence, what are the nerve fiber layers, artificial intelligence to look at what are the nerve fiber layers, and to see whether this is Sunil Moreker and not Tom Cruise, or this is not some bald actor, though he's looking like bald. So you compare that and find out what is happening. And then we do what is called as ipsilateral. There are various things that we do. Then we do endoscopic corneal neurotization. So you go from the forehead, go inside and attach the nerve. Also robotics, I'm not going to go into the details of all of this. You can also do various other techniques. Robotics is better. You can do with the trigeminal second division, you can do greater auricular nerve, you can do exoguard, cover that nerve so that the nerve grows through it. You can do cabled autografts, you can do hollow conduit nerve grafts, and you can also do substrate for processed nerve grafts as well. So these are the various nerve grafts. But what I'm trying to show you here is that what I said, that the plexus, if it is not improved, the localization which is there will sometimes come. So this is something that we had done at Sankara here in Bengaluru itself, and we did a DALC with it. Those are the incisions. This is the nerve taken in, so it's like the apple wire. You open the virulets and separate them out and put it at 8 different corners in the cornea, and then you see the nerves growing, right? And so that is pre-operative, this is post-operative. And this is the funny thing that you see. You see the patient is being touched here on this eye, and he's localizing the pain here. So the nerves have been connected. This side is neuropathic. This side is not working. So the cornea, the sural nerve has been connected to this side, taken on to the other side and connected to this supraorbital trochlear. When you touch his eye, he says, I'm feeling pain here. So this is non-localization, which is not a characteristic of plexuses. So the plexus is not yet formed. Then we look at the pediatric literature, and we sometimes find out that you can find out indirectly with magnetoencephalogram or SSEPs. You can see whether the MRI is showing any signaling after the pain, because the patient may not be able to tell you whether there is pain properly or not. There are surrogate measures. One of the surrogate measures here is vascularization. So when vascularization occurs, the neurization does not occur. When neurization occurs, the vascularization starts reducing. So this is what we did at Sankara. Those are the 6 to 7 nerves that we took out from there. These are post-op pictures. And what are the major audit findings? There are various ways of doing the exoguard, central, direct transfer, take the sural nerve and put it on this side, ipsilateral, contralateral. So there are various techniques like batsmen. So what are you going to do? Which technique is going to work for you? That is what the molecular scientist is going to tell you. I hope he's listening to us. So this is one of the latest paper which says that the mechanisms of corneal regeneration need molecular considerations. These are the list of molecular considerations that you're looking at. You're looking at these factors. You're going to look at assays. You're going to look at tear film biomarkers and find out if the nerve is actually growing, because the nerve will show the nerve growth factor in the eye, in the tear. The nerve will grow much later. So it is possible for you to tell the patient that we continue the treatment. And this is various levels at which it works. So I'm just throwing you a brainstorming and we can discuss this over dinner. The functional recovery is a different thing. So many times I've seen that the confocal shows all the nerves have come in back, but the patient's symptoms have not improved at all. His pain has not recovered, his pain sensations are not recovered, his touch sensations are not recovered. Nothing is recovered, though the corneal nerves are there. So this is at the iron level. So you look at what Dr. Rohit was talking in the morning. The subapical is TRP1, TRPV1 independent, and the lower, the subbasal, is TRPV1 dependent. So if these markers are not there, you may have confocal showing. It's like retina is attached, but the patient doesn't have any vision. Right? So the functional aspect goes on this. So what are the various types you have? You have direct, you are taking the supraorbital and supratrochlear, putting onto the ipsilateral, or putting onto the tunneling and putting it into the contralateral side, or you're taking indirect, you're taking the sural nerve and putting it on ipsilateral side, you're putting it on the other side. So there are various things that you do. When we did the endoscopic things, we realized that endoscopy is better, but invariably what happens, like you're doing small incision surgery, we started doing small incision neurization. So what happens, the coat is left behind. You're trying to push Sunil Moreker through a narrow door, the coat is left behind, the stem cells are gone. Then the other thing that is there that Dr. Rohit talked about, the VEGF-A and the VEGF-B. So there are many times when people said that there is a lot of neovascularization, let's use an anti-VEGF. Now when you use an anti-VEGF, if you block the anti-VEGF-B, anti-VEGF-B is important for neoneurization. So there is something called neoneurization, which is conversely related to neovascularization. So if neovascularization increases, neoneurization goes away. So the other concept was they inhibit each other in the cornea, and there are other factors, VEGF-R3 and VEGF-C. And what you see is that if you put a pellet in the cornea, and you see and take out that cornea and then look at the nerves there, where the pellet is there and vascularization is occurring, the nerves are gone. The other area where the pellet is not there and the vascularization is not come in, the nerves are there. So what I am showing you here, this is an endoscopic case that I have done, and you can see the area down there. I don't know, you can see the area down there, there's a lot of vascularization, and then as the nerves grow, the vascularization is completely gone and the opacity starts shrinking. And then you do a keratoplasty and that it functions. Now, otherwise, what happens is you do a keratoplasty, this is the first time the keratoplasty was done, there is a neurotrophic ulcer even in the corneal graft, and that has failed. When you do it later on with the cornea nerves intact, you can see them. What you do, whether you do end to side, you take the sural nerve, attach it side to end, or you do side to side, open up both the sheaths and attach them together so there is a channel available, that is a different issue altogether. Cornea pockets and other modifications. What is important here is the role of DEOSS layer. So the subplexus nerve fiber grows over the matrix of the support of the DEOSS layer. If by chance while doing the neurotization, if you have damaged the DEOSS layer, there is absolutely no help that is going to happen to the patient. We did the nerve growth factor assays in the cornea, where in the tears, and this is what we found, that if the DEOSS layer is disrupted, it is gone. You look at the anesthesiometer and structure function doesn't match. These are some of the results. And depending on the severity, if you do an indirect, that will grow faster. But if you do a direct, so we thought that the peripheral nerve works better. But if you put a direct, it is like putting Rohit Shetty in front of oculoplastic surgeons. All of them will get induced to become corneal surgeons. So the mesenchymal tissue there, because of the presence of a direct, a central nervous system, that will not grow the Buckner's bands. But when you see that the nerve is here, it has not grown in continuity. It has induced neoneurization in the center of the cornea without the nerve reaching there. So when you want to do something fast like that, functional recovery is a different game altogether, robotic assisted different game altogether, and these are all the factors. In conclusion, it is a definitive thing. If somebody comes to me and tells me that I have grown bald, I say to patients sometimes that I have given you a lot of oil, a lot of things to rub, your hair is not growing back, I think it is time for a hair transplant. So, but this is very complex, and you have to understand that it is a hair-raising experience. Anybody who has kids knows that there's a hair-raising experience. Anybody who's tried hair transplant knows it's a hair-raising experience. So if you can grow hair, you can definitely grow nerves back into the cornea as well. But provided the follicles are there. If I try to grow without the follicles, it is not going to grow. Thank you. Thank you. That's my mobile number. Anybody needs anything?